Thank you very much. We're now going to the Convocation Lecture, and it's my pleasure to invite the Faculty Secretary, Faculty of Psychiatry, Dr. Akinola, to present the citation of our Convocation Lecturer.
The representative of the Honorable Minister for State for Health, Mr. President, sir, the principal officers of this college, and permit me to stand on the already established protocol. It is with a humble heart and great joy that I stand before you this morning to read the citation of a living doyen of psychiatry in Nigeria. Professor, thank you very much. Professor Owoidoho Udofia. After graduating from medical school in 1979, and completing his house job at the Ahmadu Bello University Teaching Hospital, Zaria. And he had his NYSC in Iwo, then in Oyo State. Dr. Owoidoho Udofia returned to Calabar. He had been assured that he would get his residency position after sending his NYSC discharge certificate. While awaiting his residency training position, he took the only vacant position no doctor wanted to fill. That is the medical officer in the Calabar Psychiatric Hospital. By the time his letter came from ABUTH, he had recovered psychiatry, rediscovered psychiatry, and it was magic for him. His entire being and the specialty became a perfect blend. With mentors sent from heaven and the comparative advantage of his personality endowment, mastery of the subject was inevitable. He was formally trained at the Federal Neuropsychiatric Hospital, Aru, Abeokuta, which was still a World Health Organization collaborating center in research and training in mental health, and Royal Southampton Hospital, Southampton, where he spent his year abroad. Professor Udofia dedicated his career to teaching psychiatry, mentoring countless medical students and resident doctors. And Mr. President, sir, this is evidence because a student actually gave an award to the college for the best Part 1 student in clinical psychiatry. Please give him a round of applause. He held key administrative roles, including Chief Medical Advisory Committee at Calabar, University of Calabar Teaching Hospital, Calabar, and faculty chairman in the National Postgraduate Medical College of Nigeria. He significantly influenced the development of psychiatry in the college, both in Nigeria, in the college and in Nigeria. He served as faculty secretary and chairman of psychiatry. He chaired several college committees in the National Postgraduate Medical College. He also contributed to West African College of Physicians as an examiner and council member. Professor Udofia actively participated in medical politics, serving as president in the National Executive Committee of MD-CAN and as president of Association of Psychiatrists in Nigeria. His research focused on psychometrics, psychiatric epidemiology, and psychosomatic medicine, particularly on culture-borne somatic symptoms. He received numerous awards and fellowships for his contributions to the field, which includes the following. He is a member, World Psychiatric Association. This particular one, Nigeria, is usually countries that are member of World Psychiatric Association, but they also give membership to individuals. So Prof is one of the 2 people in Nigeria that is a member of World Psychiatric Association. He has received Distinguished Fellow of the Association of Psychiatrists in Nigeria, Distinguished Fellow of Medical College of Nigeria. He is also a Fellow of Nigeria Academy of Medicine. Well done, sir. After a long and impactful tenure in Calabar, Professor Udofia served as college registrar at the National Postgraduate Medical College of Nigeria. During his 4-year term, he led a team that religiously implemented Senate decisions that caused significant changes in the college, including a digital management system for residency training, which I'm sure all the resident doctors are enjoying now, and examination management. His team also initiated curriculum changes and examination standardizations, leading to improved pass rates. Additionally, he played a modest role in negotiating a direct PhD program for Nigerian doctors and introducing the postgraduate MD program. Thank you very much. Beyond his professional achievements, Professor Udofia enjoys a fulfilling social life. I'm sure the psychiatrist in the house can attest to that. He still practices exercises every day, and he holds a black belt in Taekwondo. I do not want to find out about that. His legacy as a respected psychiatrist, educator, and administrator is evident in the numerous lives he has touched throughout his career. Let us therefore welcome the 2nd Distinguished Faculty of Clinical Sciences Lecturer, Anatomy 001, Dissecting the Mind, the 3rd Faculty Day Lecturer, Psychiatric Assessment of Politicians, Matters Arising, 127th Inaugural Lecturer of the University of Calabar, Measuring Measuring Madness. Because I have been taught over the years not to use that word. So I could not find it inside my brain anymore. Measuring madness within, without, and in between. And the 42nd Convocation Lecturer of National Postgraduate Medical College of Nigeria, Professor Owoidoho Udofia.
My president, sir, members of the principal officers of the college, members of the high table, ladies and gentlemen, I asked for the list of protocol. I was told I would just stand on existing protocol. So I do that. I stand on existing protocol. I don't know if I can have the slide, sir. Yeah. My citation mentioned I'm into psychosomatics, and this is part of the things we do. I'm talking about something we all know. Every doctor in Nigeria has had several patients who complain of internal heat, crawling, or peppery sensation. We'll give a list as we go on. I want us to understand fringe symptoms, not fringe patients. It's the symptoms that are the border. So if you listen today, I'm earnestly hoping that the next time you're going to see a patient with these symptoms, you'd have an improved understanding. I'm not sure whether it will be better, but it definitely will be an improved one, because I know that all of us, whether you are a specialist, orthopedic surgeon, or I think that's the worst anybody can do, or a physician, you would have, apologies, sir. Now, I was just talking about being a real doctor, like being a psychiatrist, and being at the fringe, like cutting and joining things. That's actually what I have in mind. Yes, my name is Owoidoho Udofia, and I teach psychiatry in the University of Calabar. Now, the outline I'll go through will be just reminding us, because we all know about several symptoms. I'll specifically look at 3 different symptoms: the referred pains and other referred symptoms, because we always forget that there are other referred symptoms. We all remember referred pains, but several other symptoms are referred. We're going to spend time reminding us also of somatic symptoms, because we meet them in our clinics whether we like them or not. Those crawling sensations and internal heat, we call them culture-specific somatic symptoms. There are also somatic symptoms, but they are culture-specific, mostly around Africa and Africans, Asians, and South Americans. We are going to also try to do a psychopathology that's looking how there's a mixture of the mind and the formation of the pathologies of internal heat and crawling sensation. And if we have time, we would look at management of the conditions. I'm saying if we have time because the college had produced a booklet, which I'm sure all of us are going to have. I'll stick to the time, sir. Okay. All right, that's Dr. Musa. His friends call him Dr. House. I'm sure some of us have watched this series. He's the best in diagnosis. Every patient who comes his way, when there's a problem, Dr. Musa is the one we call. He met Mr. K. Mr. K had some pain in his shoulder tip, left shoulder tip. And of course, because his blood pressure was on the high side, it was about 135, 93 or so, the first thought that came to his mind was probably having a cardiac issue. And of course, he did his examination, sent bloods, and did ECG, but the results came back negative. And for a first time in a long time, Dr. Musa's diagnosis did not work out fine. So he did a closer examination of him, then repeated his history of presenting complaint. That's when Mr. K told him that the weekend, 4 days or so before he came, he was painting the ceiling, painting his house, and he was reaching some awkward positions. And it suddenly occurred to the chief diagnostician that, of course, it was referred pain. The pain was referred to the shoulder tip, but it was not from the heart. I'm just using this story to remind us, because even if you are a pathologist or even a psychiatrist, once you see someone with those pains, you would know for sure that it's probably a heart situation you are dealing with. So I'm just trying to remind us that those pains still exist, and every doctor meets them. It's not just pains that are referred. There are many other symptoms that are referred. Because of the time, I'm not going to go through the list of the symptoms that are referred, but remember, several symptoms are referred. They are referred because the primary source of the symptoms are not where the patient is reporting them. So that's the core thing there. Now, if we are looking at referred pains, there are pains, of course, that occur in other sources. And to understand referred pain, we need to go into the physiology of it. I'm sure many of us remember There are several theories about it. The ones of interest I will talk about because of time will be the convergence projection theory. I'm sure we all know the meaning. Pains, fibers, and other sensories converge on the posterior horn, I think. From there, it's projected to the brain. Okay. Sometimes the brain, because of the number of fibers that are packed in, the brain sometimes confuses pain from the heart and reports them as though the patient is having pains in his shoulders. It's not just there, several other places you have such. But also, it's not just pain, like I kept saying. Several other symptoms are also referred. The other one I'll talk about is the central nervous system processing. That's another thing. But before then, maybe just to remind us, several tissues that share the same embryonic origin, pains can easily be referred to them. So we all remember that. But the brain is not just a passive organ that just tells you where pains are. It elaborates on the pain, it corrects them, it does lots of things. So sometimes the brain overdoes it, and the state of the body, the state of the mind, the state of the person sometimes influences the reportage of these pains. So sometimes, because of stress, because of anxiety or expectation, the brain distorts things. I'm sure many of us have experienced that when you are expecting maybe alerts from your bank, someone closes the door, you think it's the alert that has arrived and you run to look at it. The brain does that because of a state of expectation and stuff. So the brain makes errors once in a while. And usually when we check the phone and there's no alert, we understand that the brain was just playing on us. So that's usually not a problem. So this is what I've just explained, that two people may have the same symptoms at the same place, while one person's brain interprets it as sheer inconvenience. In other people's brain, they're interpreted as calamity. Now, I've also mentioned the referred symptoms, but let's drop referred symptoms because I'm sure when you go through the booklet, you'll see lots of things about it. There's another group of symptoms. We call them somatic symptoms. Somatic symptoms, forget the name. It's old names because many people thought at a time, so we're called somatic symptoms now, but in history, we used to call them medically unexplained symptoms. I'm sure we all read them during our 2 weeks or 3 month study of psychiatry in the medical schools. Medically unexplained is a bit funny. Every symptom we have is caused by the body. There are no bodies that, you don't have symptoms from external sources. It's all part of you. So whether it is from the body or from the mind, we are not differentiating anymore. All symptoms can be so explained. They are now called somatic symptoms because you may not find the real cause for it. Or sometimes the causes are more of an exaggeration. Maybe a little thing happens and the patient reports it in a larger way. So that sometimes happens. Now, for symptoms to be somatic symptoms, there are some conditionalities that they must meet. And part of this conditionalities, the specific thing you'd see in the patient with somatic symptoms is the way the patient excessively worries about his symptoms. I've had a patient who came to tell me, during anatomy, I never saw the opening of the tear duct, tear gland. What was that? I can't remember the name. But a patient told me that he has a hole in his heart, in his eyes. And I said, where is the hole? He showed it to me. So that was the first time I saw the opening of the lacrimal gland. But it's a worry to him. It was a normal thing that he had. We all have it. But for him, it was a big issue. And all his symptoms were based on it. So one of the core things is the excessive worry. The other thing that's important is that the patient would go from one doctor to the other. So if you are a doctor and you see a patient, know that he has gone to 2 or 3 or 10 other doctors. It's also important to remember that in taking whatever decisions you are going to take. Because if you remember, you might get lots of useful information from the other doctors he went through, and it will spare him lots of money and probably some unnecessary surgical interventions you are going to do. Now, the patient is disproportionately distressed. Like I mentioned, something normal that has happened, but is so distressed and worried about it. Some of them are so disrupted that they can't keep their job anymore. I'm sure many of us may have friends who are so worried about it and they can't even go to work or do any other thing. And the last of the list of the things is that it greatly reduces their quality of life. So these are the core things. If you see a patient with any symptoms and they meet this criteria, then you are definitely dealing with somatic symptoms. We'll talk about them as we go on. There are theories about somatic symptoms. We may look at two of them in any details. The first one is called alexithymia. These are just the basis, that the patients have reduced ability to connect emotions to bodily sensations. If you've sat for a long time and you have back pain, you may think that is your sitting arrangement that is responsible. Patients with alexithymia do not think that. They just have back pain. They fail to connect it to the emotions that are responsible. Someone is hungry, his stomach is making lots of noise. His interest is in the noise the symptoms are making, not the hunger. There's a great disparity between the emotions and the symptoms. So the patients with alexithymia have reduced capacity for introspection. They won't even give it a thought. You talk with them, how are you feeling? Good. They're not interested in explaining anything about the good. Are you okay? I'm fine. You understand? Those are patients who are likely to have alexithymia. They don't connect the emotions to the things they say. Now, the other thing that is interesting is about how we grew up in Nigeria. We did a study some years ago, and we found we had to interpret some WHO documents into the three major Nigerian languages: Yoruba, Igbo, Hausa, and Efik. Efik is not one of the major, but we had to do that. And we noticed that in many Nigerian languages, you have just one word for happiness, one word for unhappiness. So if someone is sad, he's saying he's unhappy. Someone is anything bad in that spectrum of, let's make good. For example, the English have joy, glee, delight, euphoria, and many other words to express happiness. But we have only one or two words in most of the languages in Nigeria. In many of those Nigerian languages, there are no words for anxiety, there are no words for depression. So someone who is anxious, how is he going to tell you about it when there are no words for it? That is where the Sapir-Whorf hypothesis comes in. It's called the relative theory of language. I'm sure we all remember relativity theory. The one for science by Einstein, from it people have done many things. But in languages, the core thing about that theory is that we can't think of what we have no words for. Whatever you don't have a word for, you cannot think about it. And we never would know how it interferes with our behavior. In Nigeria, there's no word for snow. We don't need to have words for snow. The English, for example, have like 40 different words for snow. And the Scots, a bit north, have 400. Why does it matter? If you are driving in, say, any of those countries and you see, beware avalanche. I'm sure we all remember what avalanches are. Does it influence your behavior? Of course it does. You change how you drive. You become more cautious. And if possible, you won't even go near the hillsides, mountain sides. I'm trying to say that we lose a lot because we do not have words for it. So in English, we try to differentiate apprehension from anxiety. In our languages, we don't even have any words. So how will you differentiate anxiety from apprehension from all the other words? So many of our patients, many of people from our place do not have enough repertoire of words to reason and to take decisions. The other, the last of the theories for somatic symptoms would be what is called somatosensory amplification. This is a tendency to perceive normal bodily sensation as unusually intense, disturbing, and noxious. Normal body feelings. You've been sitting for some time. If you stand up, you may feel a bit dizzy. You would, maybe because you are a doctor or you've lived long enough, you'd know it's because you changed your position. But the person who is suffering from alexithymia would see this as something big. He'll tell you in the clinic, doctor, when I stand up, my head is turning like, you've all heard them. So I don't need to tell you about the symptoms I'm talking about. Now, that is the core thing with somatosensory amplification. And it's normal. Anything that occurs in normal existence, there are people who are more sensitive to their body than others. But people with somatosensory amplification are extremely so. There's an example, think about swallowing water and you are feeling it track down the esophagus and all the way down. Some people are capable of having and perceiving such sensations. So, people who have such things are more likely to have those, when normal bodily functions occur, they perceive them, they pick them up, and they make a mountain out of it. So these are the core causes of somatic symptoms. Now, we'll talk lastly about our culture-specific somatic symptoms. There's a long list. I'm sure you've met one or two of them, and I doubt anybody can practice medicine in Nigeria for any year without seeing patients with that. Crawling sensation, heat, burning, peppery, pinching, heaviness, throbbing, all these things are there. And like I said, they exist in every part of the country. Core thing is that 20% of patients in primary care present with these symptoms. Between 35 to 70% of patients seen in teaching hospitals have them. One would wonder why there's such a jump in teaching hospitals. Remember that in primary care, many people go maybe for headache, they take children for immunization and stuff, so it's a bit diluted. But in hospitals, sometimes it's up to that proportion. Why I'm stressing this is that each person who is a doctor has experienced patients with this. All right, so these are the same things that the people with culture-specific somatic symptoms also have all those symptoms, all the conditionalities that I mentioned for somatic symptoms. So apart from having the list of symptoms, they also have those characteristics of excessive worry, frequent running from one doctor to the other, functions disrupted, and quality of life depreciated. The person who drew the attention of the world of doctors to this internal heat and crawling sensation was a Canadian psychiatrist who worked amongst Nigerians, I think in the western part of Nigeria. He coined it brain fag syndrome because the students he saw told him that their brains are fatigued. Okay, I'm sure we've all heard about brain fag syndrome. I bring it here because that was the first time that the medical world knew about this culture-specific somatic symptoms. And it was interesting that each of the people with those brain fag symptoms presented with one of these. But now you don't need to wait. Many students don't even have it anymore. But the symptoms have now commonplace, and many of the doctors have seen several people about it. The psychiatric world, when Prince did this, were excited about it. And soon they saw that most of the patients who had anxiety or depression in Nigeria had these culture-bound somatic symptoms. And because of the sheer number who had Nigerian psychiatrists were able to draw the attention of the world to the fact that depressed patients in Nigeria do not have those guilt feelings, but they present with culture-specific somatic symptoms. So because of how important it became, many psychiatrists now started believing that everybody who has culture-specific somatic symptoms may be having a mental illness. And for years, they thought so until 3 different psychiatrists, my predecessor, all of them fellows of your college, were the ones to draw the attention of the world to this fact. The first person there, I did part 1 with him, so he's a big guy, Dr. General Okulate. Many of us may remember him in the governing board because he used to represent the army in the governing board. He did a study and clearly stated that patients with depression present with the traditional symptoms of depression. They have lowered mood. They do not only always present with culture-bound somatic symptoms. So we cannot say everybody with it has a mental illness. Okafor, for his dissertation, National College dissertation, mentioned that people who have culture-bound somatic, he did a big study and discovered that about 60% of the patients who had culture-bound somatic symptoms do not have mental and behavioral disorders. But he mentioned that some of them have, and for them to have, they must have several of the symptoms, 3 and above. They must say the symptoms are severe, and they must also have had it for over 6 months. So if you see someone with those culture-specific somatic symptoms, several symptoms, severe, any of them severe, and it's been going on for more than 6 months, the chances are they may be having mental and behavioral disorders. The last person, also a recent doctor, checked corpus, and he mentioned that, noticed that many of them, like 40% of them, had those symptoms. I'm going to tell this story so that you know that your patients who have them do not necessarily have to have mental and behavioral disorders. They don't always have it. So it's up to you now to see what they are and know what to do. Since we've said that they don't always have mental illness, many people thought that they're just defense mechanisms. I'm sure some of us remember what defense mechanisms are. Some other people say they are idioms of distress, but they don't really fit to defense mechanism, because if you have a defense mechanism, the symptoms are supposed to reduce. But people have this cultural somatic symptoms, and the symptoms don't reduce. So they are not a good defense mechanism. They are not even really idioms of distress. We have idioms of distress. In my place, we say, my heart is bitter. I'm sure in our different languages, patients say that. So those ones are idioms of distress, not crawling sensation or internal heat. So they are not really idioms of distress. Raymond Prince, who proposed it, mentioned that maybe the Africans have difficulty since they don't have the words to express emotional things. Maybe because of malaria, they say it's internal heat they have, or because of the hookworms and stuff, there's crawling sensation. But it doesn't really hold up. And so for us to understand it, we need to check other conditions where patients have similar symptoms. I'm sure many of us remember that neurological disorders, people have peripheral neuropathies, multiple sclerosis, Parkinson's disease, and these patients present with the same set of symptoms, only that you may find the illnesses when you do investigations. So what we did was, and also in drug use, they have what is called formications when they're using CNS stimulants, or they're recovering from alcohol and opiate addiction. Many of the patients have, yes, thank you. So, so that means that they may be having something physical. If the brain is able to report, that means there's something and we don't really know. Now, because of the time, I should really go on to No, you need to know. So the amygdala response is important. We all remember the fight response. What's the fight-flight response, and what it does is that the amygdala is responsible for showing all those symptoms. But the symptoms the amygdala shows is more symptoms of hyperarousal of the brain. We remember that they show hyperarousal of the brain. So what we think is that the hyperarousal forces the brain to perceive symptoms even in the absence of them. Because the brain is hyperaroused, it now reports that it's having hallucinations. There's no thing crawling on his leg, but the person sees it as crawling sensations. So basically, what we found is that people who have more life events. Life events are changes that people are forced to react to. Someone loses a relation, the car gets bad, cost of petrol goes up. These are all life events. When people have several life events, especially if they are prone to somatosensory amplification, the body is having one type of arousal or the other. They all merge together and the person starts having those crawling sensations and peppery feelings all over the body. Luckily, you all have booklets that give details of this, so I implore that you take a look and go through all this because it's going to make you get to see your patients better. Now, in managing patients with culture-specific somatic symptoms, there are important core things you need to take in mind. Given the prevalence, we all would see patients, that's number one. Because they also have excessive health-related thoughts and feelings, they would come to your clinic, the only patients who won't miss appointments. And when they come, they're going to start all over with their somatic symptoms. So the chances of being distressed each time you think about seeing the patient is much. So when you are managing the patient, have in mind that you need to wear the cap of a good doctor and talk with the patient. He's not creating symptoms on his own. He has legitimate symptoms. So you should validate the symptoms. That's the core thing. Establish the diagnosis. Establish therapeutic relationship with him, empathy. Validate the symptoms. He has them. Try to investigate his physical condition as much as you can. And if the number of the culture-specific somatic symptoms is more than 3, and it's severe according to his own definition, and it's been on for more than 6 months, you refer the person to the psychiatrist. If it is not, you handle the person. In handling the person, you may still need other doctors. Some of them you may need to liaise with the neurologist or rheumatologist to understand the symptoms. But it's important that you give the person frequent short appointments. Know that you are the medicine the person is taking. Talking with the person is the medicine you are giving him. He comes, you talk with him. Remember, he's going to go through many other doctors. So try and coordinate things, because if you allow him, he'll see all the different specialties because of the symptoms he's going to have. And it's important to validate, agree with him the symptoms are there, because they are there. Also, if you can talk, if he's irritating you, then he must be irritating the relations as much. So these are all the things we are expected to do. And during your talking with him, if he still gets worse, still remember to refer him. It's not just at the beginning you refer him, you can refer him halfway through. Healthcare providers should use biopsychosocial approach, considering the patient's physical symptoms, psychological state, and cultural context. This method fosters a therapeutic alliance based on empathy, validation of the symptoms, and understanding of the patient's unique experiences, which is crucial for effectively managing culture-specific somatic symptoms. Thank you very much for listening.
Can we appreciate our convocation lecturer once more? Thank you very much. I think we can take our seats. We want to show our appreciation to the convocation lecturer And to do this will be the college president, who will present appreciation plaque to our convocation lecturer. College president, sir.
On behalf of the Senate and all fellows of National Postgraduate Medical College, it's my pleasure to present this plaque in appreciation for this wonderfully delivered convocation lecture to Dr. Owoidoho, did I get it, sir? Udofia, MD, FMC Psych, DFMC. Thank you very much, sir.
We'll be going into the Distinguished Fellowship Awards. And we'll start with our immediate past president, Dr. Akinsoya Oshibogun.